حضية to start our first webinar, which will be presented by Professor Mohammed Al-Shahrani, who is an emergency and critical care medicine consultant, who will present to us today updated guidelines and management of severe traumatic brain injury. Please, if everyone can be sure that he's muted. And Dr. Shahrani, the floor is yours. Thank you. Dr. Shahrani?
أهلين حياكم.
Yes, you can start, please. Thank you.
Okay, thank you everyone. Assalamu alaikum. مساكم الله بالخير جميعا. First of all, I would like to thank you for the invite to speak to you this evening. What an important topic we all are facing daily in the critical care unit, which is severe traumatic brain injury. And mainly tonight we'll talk about, we'll cover mainly the guidelines and the most recent update. We will have some discussions about different updates in treatment, intervention, monitoring. So without further delay, so nothing to disclose, just to start with, especially when talking about guidelines, it's important to disclose any intellectual conflict of interest. I have nothing or any publication I participated in used in this guidelines or cited. So this is just to start with. So talking about traumatic brain injury, I think it's very important to have few slides covering the burden of the problem. And we all know how significant and how prevalent is traumatic brain injuries. So this is a Center of Disease Control and Prevention, United States, 2018-2019 report. I tried to summarize what their findings during that report. So they're talking about nationally in the US of having around 60,000 traumatic brain injury related deaths during 2018 and similar number in 2019. So children from birth to age of 17 accounted for approximately 4% of those numbers. And they found also it's the highest age group was those above 75 years of age. And after the count from 65 to 74, and this is a traumatic brain related deaths per 10,000, 110,000 population. And also you can notice that between 55 and 64 years of age, they have 19, so it's coming down with the, the TBI related deaths is correlating directly with age. And also they found male are 3 times prone to traumatic brain injury related deaths compared to female. And there's some, if you can see the table on the right side, having some more details about demographics, gender, also ethnicity, and others. But it's important to know what's the burden here nationally, since we are here Saudi Arabia. Do we have really some direct statistics? So the simple answer to this is there is no direct, at least from the search that I did, preparing for this lecture that I didn't find direct national level reports, but I found this one, which is annual report that the Ministry of Health used to publish in their website. And this is in the year 2022. So they reported, as you see, road traffic accident injuries per 100,000 population, and also road traffic accident death per 100,000 population. And you can see clearly that, and I think this is a good signal actually. In 2017, we were having like 102, and it's coming down till 72 last year. And also the death, it was 23 in 2017, coming down to 13 per 100,000 population. Any explanation can be postulated here. I'm not sure if this is related. Maybe we know that COVID affected at some point the transportation, and at some point there was there was a lockdown. So, but again, I don't think this is the main reason. Maybe this implementation for camera surveys like Seizure and others. There is no direct studies. Even there are some reports showing published within the last few years showing that Seizure has affected those numbers, and that's why we are getting less trauma. Here we are talking about motor vehicle accidents. So this is maybe one of the explanation, and it's again, it's a good signal. I tried also to search if there are any like direct studies toward traumatic brain injury, any in the country. And I found in Saudi Arabia, there are few studies, a scattered report. The most recent was published in 2010 by Prof. Arabi and his group, where they reported that incidence of TBI is high, with an extrapolated incidence reaching 116 per 100,000 population. Again, this is a kind of extrapolation. It's not, there is no direct, a kind of accurate statistics to tell, but this is what we have and the assumption that we have based on many other injury. They also published another report from King Abdulaziz Medical City, National Guard, and I found this a good number, but this is for multiple trauma patients. They reported, they talked about trauma characteristics, outcomes, type of injuries, and this is a study published in the Annals of Saudi Medicine. And it included 1,659 motor vehicle collision victims. And this is the table showing the characteristics of those included patients. And they compared the survivals to those who or non-survival. I'll look down at the head injury when they talked about they described in detail what happened to them. It's almost 79% in the non-survival group, which is an extremely high number. So here we're talking about a major, those who died, most of them, they had head injury. So again, it reflects the reality that we are seeing daily in the critical care departments, where those with bad head injuries, they usually at the most, affected, and prognostically, they are the poorest when you're talking about the outcome. Now we need to talk about some guidelines in the management of critical traumatic brain injury. So as you know that there are multiple guidelines out there talking about traumatic brain injuries. I found this report was really interesting, and it was interesting, and it was published on 2019 basically they did a critical review to look for clinical practice guidelines talking about traumatic brain injuries. And the aim was to assess the quality of those clinical practice guidelines and investigate the evidence grading system used there. And they used the agree-to instrument, which is the appraisal of guidelines for research and evaluation. The degree of agreement was evaluated with intra-class correlation coefficient, and there was 6 domains they looked for when assessing those guidelines, from domain 1 to domain 6. So domain 1 mainly about the scope and purpose, domain 2 stakeholder involvement, domain 3 rigorous of the development process of those guidelines, domain 4 clarity and presentation, domain 5 is the applicability of those guidelines, and the domain 6 is editorial independency. So it was a rigorous method of evaluating those clinical practice guidelines. And actually, they considered if the guidelines is recommended if more than 4 domains scoring more than 50%. So what they found that there are 12 traumatic brain injury guidelines. And you can see clearly in this table the sources and institutions sponsored those guidelines. Some of them as old as 2007. The most recent was in 2017. So the most interesting result that they, according to the criteria and the evaluation, they said the 3 best clinical practice guidelines in traumatic brain injury based on the AGREE score were Brain Trauma Foundation, and the second one and the third is Scandinavian Neurotrauma Committee, Eastern Association of Seizure of Trauma. So basically, if you look here down, the most recent one, luckily, was the Brain Trauma Foundation, published in 2017. Scored in domain 1, domain almost or more than 75 to 80% in all domains, which make those kind of guidelines as bear grading is a really good quality when it comes to applicability, involvement, rigorous method of development, and all other domains that I have just mentioned. East and the Scandinavian also was not bad, but maybe it's a bit older. The Scandinavian one published in 2013, the Eastern Association for the Surgery and Trauma published in 2015. So for this reason, I elect to choose the most recent and the highest acceptable quality, guideline, clinical practice guidelines, which is the Brain Trauma Foundation guidelines. So talking about this guideline, it started in the early 90s, actually. There was first edition, second, third, and fourth. So the fourth edition was published on 2016, actually, 17, sorry. But the good thing about it, it's a living guideline. So I will try this evening to explain a few terms when it comes to guidelines development. So the living guidelines, when they develop, like the fourth, their intention was not to develop another 5th edition, and instead they will keep updating the guidelines and publishing those new updates. So for example, in 2020, they published an update of guidelines for the management of severe traumatic brain injury, and that's mainly for the decompressive craniotomy recommendations. Last update was this year in 2022, where they updated almost all their guidelines, intervention, monitoring, and score aspects. So now we are talking mainly about the Brain Trauma Foundation guidelines. So the guidelines cover treatment, interventions, monitoring, and also they cover treatment thresholds that are specific to traumatic brain injury and that address a risk that's a greater in a patient with traumatic brain injury. We'll talk about next few slides about how they developed and what does it mean. I mean, a few terms and the exact process that has been followed to develop this guideline. So two major activities, and this is for all guidelines development. It's a kind of a must. The first one is systematic review and synthesis of the evidence. So basically, there are two main inclusion criteria, which is the population. So the population included adults with severe traumatic brain injury, and that was defined by using the Glasgow Coma Scale score from 3 to 8. Also, the outcomes of interest in this guidelines: mortality and neurological function, or appropriate selected intermediate outcome for the topic. If there was any disagreement, this will be resolved by involvement of another third reviewer when it comes to which study to be included or not. The second phase of developing the guideline was the derivation of the recommendation itself. And we'll talk in the next few slides about this. So one of the areas thing we have to tell that quality assessment and data abstraction of the individualized studies. So their way of developing those guidelines is a bit different than like a grade methodology. They are using class 1, class 2, class 3 when they assess the quality of the studies included. So basically class 1 is prospective randomized control trials, and should be a good quality ones. Class 2, and there was 5 studies included class 1 in those guidelines. Class 2, it's non-randomized prospective control trials or observational studies, and there was 46 studies included in this guideline. Class 3, which a majority of the studies included, was class 3, 136 studies, either low quality RCTs, case series, case report, or expert opinion. And there was a total of 189 publications used for evidence synthesis in those guidelines, and it was screened over the past 20 years. And there was also 2 meta-analyses included in this guideline development. The next step they do when they identify the studies, they go to identify the quality of the body of evidence. And this not only about the strength of the method, but also there are another criteria to follow in order to tell this is high, moderate, or low. So quality of individualized study, already we mentioned how they did this by classifying those studies to class 1, 2, or 3. And also they looked at consistency. So based on the results and conclusion, if all those studies all are similar when it comes to outcomes, results, included population, they will call it high, moderate if it's most, but not all. Low if no one conclusion is more frequent, so it's kind of scattered conclusions, not really similar, and not applicable if none of those criteria was there. Also, they looked at directness. So we know that sometimes you might not be able to find like a study comparing, like if you are talking about, and I will cover this in the results, about, for example, prophylaxis. If you don't find the use of heparin in head trauma, but you find the use of heparin in multiple trauma patient, this kind of indirectness. But if you find any randomized control studies address the use of prophylactic thromboprophylaxis on patient with severe head injury, this is kind of direct evidence. So study population is the same as the population of interest, or the outcome are clinical rather than intermediate outcomes. And again, they classified this as direct, indirect, or mixed. Precision, the degree of certainty surrounding the effect of estimate, And usually they look at the confidence intervals, how narrow is those confidence intervals, and the effect estimates. This is will tell how precise is the results, and they will classify it again as high, moderate, or low. And after all this, when they do, they did all this process, they ended up having rating. So either they're having high quality evidence, which is high confidence that the evidence reflects the true effect. Moderate, when there is a moderate confidence that the evidence reflects the true, further research may change this confidence in the future. Low, when they have low confidence that the evidence reflects the true effect, and probably another further research is needed to look for the true effect. And they might tell it's insufficient when they don't find any evidence supporting or really on the questions of interest. And last but not least, this is how they will categorize the grading. Level 1, again, if it's recommendation based on high quality of evidence, and we already mentioned what high quality means. Level 2A, based on moderate quality body of evidence. 2B, recommendation based study that provided direct evidence but were of low quality. Class 3, recommendation were based on studies providing only indirect evidence. So sorry for this, but I have to go over this process so we can understand what do we mean when we talk about in the next few slides about specific interventions and how do they classify or those kind of recommendation. Major changes for 4th edition, because I told you that there was a 3rd edition before that. They talked here about cerebral fluid drainage, new topic, decompressive craniectomies, deep venous thrombosis. The indirect evidence was identified, included. It was not there before. Intracranial pressure technology, they removed this. Hyperventilation, they renamed ventilation therapies. Brain oxygenation monitoring, also they renamed advanced cerebral monitoring. Infection prophylaxis, they focused more on the ventilator-associated pneumonia and also on the ventricular drain infection, and they identified some indirect evidence and used it there. Also, they looked at intracranial pressure monitoring, cerebral perfusion pressure monitoring, and advanced cerebral monitoring, and they divided this into monitoring and thresholds group. And I will show you in the next slide what the exact scope. So here we go. Now, this is the last updated guidelines, the Brain Trauma Foundation Association, where this is have been published on March 15th, 2022. And here are the scopes and the groups where they categorize those guidelines, either to treatment, monitoring, and thresholds. So now I will just try to, I'm trying to be kind of focused. I will not try to spend a lot of time talking about exact studies. Already we mentioned how they reached those conclusions. So one of the first interventions they talked about is prophylactic hypothermia. So early within almost 2 hours and a half, short term, 48 hours post-injury, prophylactic hypothermia is not recommended. And I'm sure most of the expert people attending this lecture know the story about prophylactic hypothermia. And now nobody is still recommending, and those guidelines recently confirmed this. It's not recommended because it's not improving outcomes. And actually, there are some reports talking about some side effects of using this intervention. The next intervention is hyperosmolar therapy, very widely used intervention in the ICUs. All of us using those kind of therapies. So mannitol and hypertonic saline are the two most commonly used drugs. So mannitol is effective for control of raised ICP, and the dose, as everyone knows, from 0.25 to 1 gram per kg body weight, and should be avoided if there is arterial hypotension or systemic hypotension where systolic blood pressure less than 90. And there is some, I'm taking the summary of the guidelines. So they're saying restrict mannitol use prior to ICP monitoring to patient with signs of transtentorial herniation or progressive neurological deterioration not attributed to extracranial causes. In another way, they're saying it's better to use mannitol based on a guidance or hyperosmolar therapy based on a guidance, ICP monitoring. But we all know that clinical judgment play a major role, and already they confirmed it here. If you see any signs of transtentorial herniation or progressive neurological deterioration, you can start and use. And this is the table summarizing the evidence. And interestingly, it's a very few small studies. This is the class 2 evidence, because there is class 3, but I did not cover because it's already low quality. So when they compare hypertonic saline to mannitol, if you can look at the far right result conclusion, 2-week mortality was not statistically significant, and this is already we know from before, but those guidelines confirmed this. We know that hyperosmolar therapy, when it comes to mortality, specifically at 2 weeks, it didn't have any impact. However, cumulative IC burden was less when using hyperosmolar therapy, and that's why we are using actually hypertonic saline at the end was more effective in lowering ICP burden, but did not have significant effect on mortality. The only precautions of using both drugs, we all know that hypertonic saline, we might be careful for those hyponatremic patients. Mannitol, we should be careful of those hypotensive patients. Other than this, you can use both of them or based on your clinical judgment. The other intervention covered by this guidelines, cerebrospinal fluid drainage, which is the EVDs. So we know the surgeon, they inserted EVD early in those patients. And the guidelines recommended that EVD system zeroed at the midbrain with continuous drainage cerebrospinal fluid may be considered. So we have to pay attention to the wording of those guidelines. So we saw some we recommend or recommended, and here we are starting to say may be considered because simply it's level 3 evidence. So we already know it's low quality of evidence. So that's why they are considering only or they are advising the practitioner to consider this intervention. So maybe considered to lower ICP burden more effectively than intermittent use. So you know there are 2 ways of doing this, either continuous or intermittent. So they are kind of in the favor of doing this continuous drainage rather than intermittent drainage. The use of the CSF drainage to lower ICP in patient with the initial GCS of less than 6 during the first 12 hours after injury may be considered again. They are still in favor. However, as I said, the quality of evidence here is low, but this is what we have for now. And this is the quality of body of evidence in cerebrospinal fluid drainage. You can directly look at the consistency, not applicable. Directness, yes, the study is included, but you can see it's retrospective cohorts. Precision is low, and the quality, overall quality of evidence was low. The next intervention, and this is also in the early phase of managing those patients, is the ventilation therapies. So we know that early on those patients intubated, and there is some advice to hyperventilate those patients, trying to minimize the effect of bleeding at the beginning by applying some vasoconstriction. However, we know now this can be very harmful, and it might affect the cerebral brain perfusion. So the recommendation now is that prolonged prophylactic hyperventilation with PCO2 less than 25 is not recommended. And with moderate level of evidence, hyperventilation is recommended as temporizing measure for the reduction of elevated ICB. So it's only temporizing, and some reports talking about only 30 minutes or something around this. Hyperventilation should be avoided during the first 24 hours after injury when cerebral blood flow is reduced critically. So there is a enforcement and not to overdo this intervention. And if you will do hyperventilation, you have to do it only as a temporizing measure. The quality of evidence, again, there is one single RCT included. However, the precision in this RCT was small, number of subjects was small, 113, and was classified as class 2. So the quality of evidence overall was reported here as low. After that, the next interventions, this guidelines covered are anesthetics, analgesics, and sedatives. So we all remember the barbiturate story. So what the guidelines told us during this time, that administration of barbiturates to induce burst suppression measured by the EEG as a prophylaxis is not recommended. So if you will use barbiturate as a prophylaxis, just to treat or based on the EEG result, this is not recommended anymore. And this is a class 2B, which means moderate level of evidence. However, using high dose barbiturate administration is recommended to control elevated ICB refractory to maximum standard medical and surgical treatment with moderate level of level quality of evidence. So we can say it's the last resort if the ICB is refractory and doesn't improve by maximum medical and surgical intervention, you might need to use high dose barbiturate. Propofol, as much as we know, it's used for a long time for controlling ICB. However, it's not recommended for improvement in mortality or 6 months outcome. So if you think it will change mortality, propofol doesn't do that. Caution is required, especially when patient hemodynamically unstable. And actually, the evidence showed that high dose propofol can produce significant morbidity. And this is kind of moderate quality of evidence. So we have to be careful when using propofol, especially high doses. And those are the quality of evidence. Again, if you can look at the far right, you can see that the overall quality of evidence was low. Single randomized control studies used with the small numbers, 53, 73, 42, and was classified as class 2 level of evidence. It was direct, but the precision was low in those studies. The steroid, I think everyone knows the story of steroid and traumatic brain injury. It's already game over for a long time, and it's level of actually it's a level 1 evidence. So, and maybe this is the only level 1 evidence in this guidelines. It's not recommended, and actually, if you remember, I think CRASH studies that showing terminated early because of mortality in the steroid arm. So the bottom line, no steroid in traumatic brain injury. Nutrition. So those guidelines, the good thing about they covered not only direct interventions related to the brain injury, but also the overall critical care management in the ICU. So when they talk about nutrition, feeding patient to attain basal caloric replacement at least by the 5th day, and at most by the 7th day post-injury is recommended to decrease mortality. However, the ESPEN guidelines for the nutrition in the ICU might be even you start within 24, 48 hours. You shouldn't be as late as 5th day. And also in this guidelines, they talked of transgastric and jejunal feeding is recommended, level 2B evidence. And this might reduce the incidence of ventilator-associated pneumonia. So keep in mind, feed your patient early, try to reach their basal caloric replacement as soon as possible. This is a new section in those guidelines. They talked about infection prophylaxis, and they talked mainly about VAP, which is ventilator-associated pneumonias, where they talked about early tracheostomy is recommended to reduce mechanical ventilation days. So when the overall benefit is thought to outweigh the complication associated with the procedure. However, no direct evidence that early tracheostomies reduce mortality or the rate of nosocomial pneumonias. So if you will do early tracheostomies, you might end up having less ventilator days in those patients, but till now we don't have direct evidence that it will decrease mortality or nosocomial pneumonias, and it's 2A level of evidence. Antimicrobial impregnated catheters may be considered to prevent catheter-related infection during the EVD insertion. Level 3 evidence, it's good to have it, and it might have some effect in reducing this infection risk, especially if you have your unit having a higher risk of EVD infection. So you think something that you might think of bringing to your unit. What about deep venous thrombosis prophylaxis? So in head injury, we know those patients already at risk. However, there is always a risk of increasing the intracranial bleeds, as most of those patients are already having significant bleeds. So what the guidelines tell about this, that low molecular weight heparin or low dose unfractionated heparin may be used in combination with the mechanical prophylaxis. However, there is increased risk of expansion of intracranial hemorrhage, and the level of evidence here is 3, as we know that there is no good quality studies to address this. In addition to compression stockings, pharmacological prophylaxis may be considered if the brain injury is stable and benefit is considered to outweigh the risk of increasing the intracranial hemorrhage. And again, this is level 3 evidence, which is mainly based on low quality studies, but something you may consider to do. And actually, they reported that there is insufficient evidence to support recommendations regarding the preferred agent. So whatever you have unfractionated, low molecular weight, and also regarding the timing, which is the most critical, question when we have those patients in the ICU, when to start the VTE thromboprophylaxis. And I have to mention that we are with a group of experts nationally, have just finished an extensive work regarding deep venous thrombosis prophylaxis in injury, led by Dr. Marwa Amir from King Faisal Specialist, Dr. Walid Al-Hazani. I was fortunate to be with the team and many other members from different institutions. And now, hopefully soon you will see it published. Yeah, just to cut it short, we are not far from what we are seeing in this guidelines. What I mean that there is no good quality evidence so far to cover this topic, which makes it another good opportunity to run some studies in this topic. Next, so what about seizure prophylaxis? So prophylactic use of phenytoin or valproate is not recommended for preventing late post-traumatic seizure. So we know there is early, there is late. So if you do this to prevent late, this is not recommended. However, phenytoin is recommended to decrease the incidence of early post-traumatic seizure within 7 days of injury. And again, when the overall benefit is thought to outweigh the complications associated with such treatment. However, early post-traumatic seizure have not been associated with worse outcome, but we all know that this is a practice we are having. Those with significant head injury, we give them only for 7 days, and we reassess unless they seized or something. So the story is different. At the present time, there is insufficient evidence to recommend levetiracetam, Keppra compared with the phenytoin regarding efficacy in preventing early post-traumatic seizure and toxicity. So we still going with the phenytoin. The last in the intervention group, and this is a new topic covered in this current guidelines. In 2017, there was some recommendation, or there were some recommendations regarding decompressive craniectomy, where they were saying that bifrontal decompressive craniectomy is not recommended to improve outcome as measured by the Glasgow outcome scale, extended score at 6 months post-injury in severe traumatic brain injury patients with diffuse injury without mass lesion and intracranial pressure elevation more than 20 for more than 15 minutes within an hour period that are refractory to first titer. So they were not recommending this. However, this procedure has been demonstrated to reduce ICB and to minimize days in the intensive care unit, and they labeled this as level 2A evidence. Another recommendation at that time, because I will show you the next slide what was the update in 2020, that a large frontotemporal parietal decompressive craniectomies not less than 12 by 15 centimeter or 15 centimeter diameter is recommended over a small frontotemporal parietal decompressive for reducing mortality and improve neurological outcomes in patients with severe TBI, and that was also labeled as level 2A. So what's new in 2020? Actually, as I said, this is a living guidelines. So whenever they found a very good evidence that might enrich the guidelines or need change the practice, they immediately are going to include this and releasing another update. And this is what happened in the decompressive craniectomies recommendation. Again, level 2A to improve mortality and overall outcome. The new update that secondary decompressive craniectomy performed for late refractory ICB elevation is recommended to improve mortality and favorable outcome. And also a new recommendation that secondary decompressive craniectomy performed for early refractory ICB is not recommended to improve mortality. And so they divided to late and early, and I will show you why they changed this. So when it comes to late refractory, I will show you what was the definition of late refractory ICB and what is the definition of early refractory ICB. So they are recommending this for the late refractory ICB elevation, but not for the early refractory ICB elevation. This one was not changed. It's the same recommendation as before. As we said, large frontotemporal parietal decompressive craniectomy is recommended over the small ones. Level 2A for ICB control, new recommendation. They said secondary decompressive craniectomy is performed as a treatment for either early or late refractory ICB elevation is suggested to reduce ICB and duration of the intensive care unit, though the relationship between the effect and favorable outcome is uncertain. So you can differentiate between those two. Though here talking about the mortality, down they're talking about improvement of the ICB and the duration in the intensive care units. And why they changed this? Because of these two landmark trials. Our folks, a neurocritical care consultant, they're very familiar with those, and the neurosurgeon, of course, DICRA and RESUS AB, which is the two published randomized control studies. The first one published in, this is the update actually, which is in 2020. But initially, and Dr. Arabi was one of his center, he and the center was participating in this study. And this one was talking about the early intervention outcome, but they looked at 12 months outcome, and they published this new results, because the initial publication, the New England, was mainly at 6 months outcome. But when they looked at 12 months outcome, they found different results, and that's why they changed the guidelines. Again, this one also, the trial of, which is they call the RESUS ICB, trial of decompressive craniectomy for traumatic intracranial hypertension. And this one is the one talking about late decompressive craniectomies compared to early. So the quality of evidence considered as moderate. As we said, it's a class 1 and a class 2. And that's why now, just to summarize, so now we are talking about decompressive craniectomies. When you are talking about mortality, it's for those patients with late refractory ICB, and not for early. So early, within an hour or so, you might not see any improvement in the mortality. However, you might see improvement in the ICB, improvement in the ICU days for both early and late. Now, the second section of those guidelines are talking about monitoring, which is intracranial pressure monitoring. So the management of severe traumatic brain injury using information from the ICB monitor is recommended to reduce in-hospital and 2 weeks post-injury mortality. We all know the discussions before about should we monitor ICB or go empirically, but now the recommendation is very clear that this is something those severe traumatic brain injured patients will benefit from, and it's level 2B as a quality of evidence. Again, ICB should be monitored in all salvageable patients with TBI, GCS 3 to 8 after resuscitation, and abnormal CT scans. And abnormal CT scan of the head is one that reveals hematoma, contusion, swelling, herniation, or compressed basal cistern. So this is the criteria where you need to monitor the ICBs. The CT findings or the GCS scores after resuscitation. Again, ICB monitor is indicated in patients with severe traumatic with the normal CT scan. And again, if normal CT scan with one of the following feature, ICB should be monitored: the age more than 40, unilateral or bilateral motor posturing, systolic blood pressure less than 90. So there are different description here when you need to monitor ICB, but you can feel that it's you have to have low threshold to monitor ICB in severe traumatic brain injured patients. What about the CPP or cerebral perfusion protein management of severe traumatic brain injured patient? It's recommended to monitor their CPP and the quality of evidence, and this might decrease the 2 weeks mortality. Actually, the quality of evidence is 2B. Advanced cerebral monitoring. So I'm sure most of you here are familiar with those advances in technology, the jugular pulse monitoring for AV oxygen content difference as a source of information for management decisions may be considered to reduce mortality and improve outcome at 3 and 6 months post-injury. Level 3 evidence, because it's based on a low quality of evidence, but something, if you have it, you may consider. Thresholds, there are 2 or 3 thresholds that they covered during this guidelines. The first one, and very important one, because this is from the early phase of encountering those patients, we need to be careful in maintaining systolic blood pressure more than 100 for patients from 50 to 69 years of age. At 100,
Shahrani?
yes, please.
Yeah, I think your slides are not moving. They are static.
Which slide you stopped? I'm not sure.
Monitoring intracranial pressure, the thresholds, the age more than 40, unilateral or bilateral motor posturing, and cerebral systolic blood pressure less than 90.
What
That's
about
what we stopped at?
which one you see now? Because it's only 2 slides after that. Is it moving now or not?
No, still, it's the same slide.
So if you allow
Age
me,
more than 40. Yeah, you can check it out.
just give me a second. Any changes? No.
No.
Yes, it's okay now.
Let me see. What about now? So you
Yeah,
see,
now, yes. Yeah, cerebral perfusion, pressure monitoring, yes.
you didn't miss a lot because it's only 2 slides. So I talked about cerebral perfusion pressure monitoring, and I said the guidelines said actually it's recommended, and this might decrease the mortality, improve mortality, 2 weeks mortality. It's level 2B evidence. I hope it's moving now, the slide.
Are
Yes.
moving.
Okay, good. So now the advanced cerebral monitoring, which is, as I said, it's one of the new technologies talking about jugular pulse monitoring for arteriovenous oxygen content difference. The guidelines said you may consider this kind of monitoring tool if you have it in your unit, and this might reduce mortality and improve outcomes at 3 and 6 months post-injury. Again, it's a level 3 evidence, so we know the quality of evidence is not really high. It's low, actually. The last threshold is a blood pressure threshold, and it's very important to maintain systolic blood pressure more than 100 for those patients from 50 to 69 years of age, and more than 110 millimercury or above for patients from 15 to 49 or more than 70 years of age. And this is something you may consider to decrease mortality and improve outcomes. Level 3 evidence. So what about the ICB thresholds? The Brain Trauma Foundation guidelines mentioned that treating ICB if it reaches more than 22 is a must, and it's recommended because values above this level are associated with increased mortality. And this is level 2B evidence. A combination of ICB values and clinical and brain CT finding may be used to make management decisions, because we know sometimes you need to gather a lot of information about the patient, how the patient clinically, if this needs, you might see numbers, but the patient is really doing fine. So this is, again, it's need a collective kind of information so you can make a decision. Cerebral perfusion pressure thresholds, the recommended target, and I think this haven't been changed for a long time. It's from 60 to 70 and is level 2B evidence. And we should avoid aggressive attempt to maintain cerebral perfusion pressure more than 70 with fluid and pressors. And this is because of the complication that might happen of flooding those patients of fluid. So something you may consider, especially this might affect the respiratory system and causing affecting the oxygenation and ventilation of those patients. What about advanced cerebral monitoring thresholds? The jugular venous saturation, something I'm sure most of you heard about recent years, may be a threshold to avoid in order to reduce mortality and number of outcomes. So you need to target more than 50% jugular venous saturation. in order to avoid bad outcome on those patients. Again, it's level 3, so still further research needed to prove or disprove this. And by this, I conclude, and thank you, everyone. I'm happy to have any questions, and thank you again for inviting me this evening.
Thanks, Prof. Shahrani, for this comprehensive talk. The floor is open for any question or any queries that any one of the attendees have. If you have any question, just raise your hand and I will unmute you.